Thank you very much. And I'd like to welcome you all here tonight for week 2 in our series, How to Survive and Thrive with a Mentally Ill Relative. Tonight we're going to be focusing in on the treatment for bipolar disorder. Last week we began by understanding bipolar disorder. And as we go forward tonight, during the latter portion of this evening, I'm going to be joined by a guest speaker by the name of Erin, and Erin's going to describe her experience in dealing with bipolar disorder and her story of recovery. And I think, like myself, you will find yourself inspired by what she has to share with us. So I think we have a lot to look forward to tonight. And I think tonight is especially meaningful that we're here providing education on the topic of mental illness. Given this week's events in our nation's capital with yet another violent shooting, there will sure be lots of information to come out, a lot of speculations that will come out of that, a lot of blaming and shaming that comes out of that. And I think it's something that we as a community need to be clear in how we want to respond to that. So often it's looked at, it might just be said that this is what happens with mental illness, and I think very clearly our response back has to be, this is what happens with untreated mental illness. And that is why it is so important that we educate and we advocate around mental illness. And it's so important that you're doing what you're doing tonight, which is getting that education, because it empowers you as you go out, not only to work with your relative, but with the community at large. And so with that, let's move in and talk some about bipolar disorder. Last week, we began by describing these disorders. And first we said that bipolar and related disorders are biologically based brain illnesses with strong genetic factors. So at the cause, biology, and genetics. The hallmark symptoms of bipolar disorder are those mood swings. We talked about the highs of mania, the lows of depression. We said that bipolar disorder is an equal opportunity disorder in that it doesn't discriminate and it exists everywhere throughout the world in approximately 1.5%, 2% to 6%, depending on how we look at it, worldwide. Worldwide. We talked about the average age of onset between 15 and 30. Generally, the younger the person is diagnosed with the disorder, the younger the onset of the disorder, the more severe the form of the disorder. We talked about changes that occur in the brain in adolescence, which when those go awry, trigger the onset of the disorder, which is why it is that late teens into the 20s that we see it most commonly. We said that bipolar disorder is a recurrent disorder, meaning that 90% of the time, individuals who have an episode will experience another episode. So unfortunately, it's not like many things in life where you can learn your lesson and it never happens again. We know with this disorder, it will be recurrent. It will come back again. We know clearly that there is no cure for the disorder. However, and the reason you're here tonight, is that we know that when we provide the right treatments for the disorder, we can greatly improve the quality of life. We can greatly help folks go forward in their life in recovery with this disorder. I want to just read for you one description by Kay Redfield Jamison, author of An Unquiet Mind. She said, manic depression distorts moods and thoughts, incites dreadful behaviors, destroys the basis of rational thought, and too often erodes the desire and will to live. It is an illness that is biological in its origins, yet one that feels psychological in the experience of it. An illness that is unique in conferring advantage and pleasure, yet one that brings in its wake almost unenduring suffering and not infrequently suicide. I am fortunate that I have not died from my illness, fortunate in having received the best medical care available, and fortunate in having the friends, colleagues, and family that I do. And so with that, she invites us to reflect that with that good treatment, we can move forward and recover. And let's talk about the 4 pillars of treatment that promote recovery. Starting at around 7 o'clock there on the wheel, we're going to first talk a little bit about medication and how with a biologically based disorder, it just makes sense that we're going to have a biologically based treatment, which is medication. We'll start talking about the therapies and rehabilitation models that are most helpful for folks with bipolar disorder. The importance of support and empowerment, family support, peer support, to connect, to realize that I'm not alone in this. And having that support can be very empowering. And then we'll talk just a little bit about just healthy lifestyle adjustments that can be made. And a lot of those we'll see are things that might be healthy for all of us, but are especially important when we're talking about somebody coping with bipolar disorder because of the effects that it has on the brain, as we talked about last week, the impact of stress, the impact of when the circadian rhythm cycle, the sleep-wake cycle gets thrown off. And so these lifestyle adjustments will be very important as well. So these are our 4 pillars of treatment. And as we go forward with this, a good philosophy to keep in mind, that I like to keep in mind whenever I'm dealing with bipolar disorder, is imatio stat virtus. Now I'm sure most of you in this room speak Latin and have translated this, but for the 2 or 3 of you that perhaps haven't brushed up on your Latin, imatio stat virtus means virtue stands in the middle, meaning that we're going to be looking for balance with this disorder. We're going to be looking for balance. That so much of this disorder is a disorder of extremes, highs, lows, too much energy, too little energy. So many different extremes are present with the disorder that as we talk about treatment, so much of what you'll hear about will fall under the subtitle of balance or being somewhere in the middle, which is where we're going to be trying to help folks be. So keep that in mind as we go through tonight. Your Latin lesson for tonight, imatio stat virtus. So let's begin by talking a little bit about medication. And as we start talking about medication, I want to first begin by saying that medication is a trade-off. We read the books, we learn the information, and we hear that we got to have medication. We need medication. And is it the foundation? Yes. However, it's no panacea. We know that most folks don't like taking medication. And so we want to be clear about that up front, that it's not just this magic pill and it's wonderful, and you should just love to take this. While we all would love you to take it, we recognize that again, while it's the foundation of treatment, meds are no panacea, because there is the good and the not so good. Certainly there is the good. Medications will stabilize symptoms. They'll stabilize the biology, the chemistry. They'll help improve that mood, balance it. But there's the not so good. All medications bring side effects. We have to deal with that. Medications help stabilize biology, but they don't necessarily help restore the broken relationships or give the person a job or that success in school back. And so we know they're not a cure as well. So a way to think about medications is that meds put you back in the driver's seat. They'll put the person back in that driver's seat, but they're not going to teach them how to drive the car. And so we want to realize that. Our first step here we're talking about is meds, helping the person get back in that driver's seat, where they can manage and be hopefully in more control of their own life. Then beyond that, all the other tools and skills we're going to talk about are going to be how to help them drive that car. Where do they want to go in life? What are their goals, and how will we help them move forward towards achieving that? Some general considerations with meds. Again, ambivalence is to be expected. We want to just say, just take this. You'll be better if you take it. I'll be happier if you take it. You will feel better. Recognize the person's going to be ambivalent about it. We have to normalize that. Know that most people will stop taking their meds. It's part of what we deal with. Most folks are going to stop taking their meds at some point in time for various reasons. I'm not really sick. This wasn't bipolar disorder. I don't have that. Or that side effect. Sometimes it's described as it feels like this emotional straitjacket. As we talked about, and you even heard about that quote, there's some excitement about living with bipolar disorder that the person experiences. So those highs of mania. Sensuality is more pervasive. Things are more exciting. Who wouldn't want to lose that, right? Who would want to have that taken away from them? Meds can have that experience of being like in the straitjacket. I don't have those really wonderful feelings and that excitement that I had before. So we have to recognize this, that again, most people will stop their meds at some point. You know, when medications were first discovered, the very first person who took lithium, and again, accidental serendipitous discovery that even lithium was discovered, first person that tried it, took it, started getting better, 6 months later, went off for lithium, and experienced the throes of the illness yet again. So we've been dealing with this throughout our time of medication, just what we expect and what happens. Another thing just to know is that what we'll call polypharmacy, taking more than one medication at a time, is the norm. In fact, on average, folks are going to be taking 3 or 4 medications, and maybe a third will be taking just one medication. So again, if this is what's happening, what's being prescribed, know that it is more the norm than it might have been some years ago, as we're trying to mix things to see what will work best for the person. I'm going to talk just a few minutes about some of the specific medications. And again, I won't go into it in too much detail because medications are really unique to the person. What works for one doesn't necessarily work for another. We have some general guiding principles in this. However, what works with one may not be what works best with the other. But our primary medications. Now, when we're talking about bipolar disorder, really the hallmark is that someone who's experienced a manic episode is someone who will be diagnosed with bipolar disorder. And so the medications that are there essentially are anti-manic agents. They really help with treating the mania, more so than depression. We'll go into that a little bit more. And so the most common medications, you may be familiar with some of these, lithium, Depakote, and now the novel or atypical antipsychotic medications. Those are going to be the 3 most common that we're going to see as a first choice. And then also, I just tossed in here, Lamictal is the first FDA-approved medication for depression in bipolar disorder. Now, why is that important? If someone diagnosed with bipolar disorder, perhaps it was missed, they come in just complaining of depression, and they're given one of the common antidepressants, Prozac, Zoloft, etc., good medications for depression. Very high risk that someone with bipolar disorder would shoot up into a mania if they were taking only antidepressant medications. Because what it's doing is it's elevating that mood, but without a ceiling. So it just elevates it and a risk that we're going into mania. Lamictal, again, the first FDA-approved medication for the depressive side of bipolar disorder because it does not bring with it that risk of shooting somebody into mania. So that's a very good thing we want to remember about Lamictal. In terms of the medications, again, just to briefly run through, lithium has traditionally been the choice for what we call classic bipolar disorder. Folks who don't experience the mixed episodes and the rapid cycling, etc. And so this has been kind of the classic choice. It was the first medication really for bipolar disorder. It certainly has an established history in the research as being effective for the maintenance of the mania and depression, especially the mania. It's good for acute mania. It's significant. It shows significant reduction in suicide with its long-term use. But of course, as they all will, it brings side effects here, including weight gain, that straitjacket effect I alluded to earlier, and the fact that lithium is a salt. I want to remember that. Especially important for us here in Southern California. Right? What happens when we're out in the heat? We perspire. What's coming out of our body when we perspire? Salt. So we want to be clear, or be careful with that if we're exposed to a lot of sun, a lot of sweating, things like that. Just again, we're going to be focused on how we keep that balanced in the body. Both Depakote and Tegretol not used as much anymore, but still may be used. These are both anti-seizure medications and are shown again, Depakote, for example, effective in treating that acute mania. And studies suggest it's better than lithium for rapid cycling. persons who experience that fluctuation from highs to lows very rapidly, or those mixed episodes, folks who experience both mania and depression at the same time. I described it as that tired but wired feeling last week. So Depakote is going to be a little better for that. One of the things that we see in the brain in research is that folks with bipolar disorder have higher incidence of lesions on the brain. Now what happens when there's lesions on the brain? Lesions on the brain are also what happens when we see seizures. So again, some overlap, right? Perhaps between some kind of seizure disorder and bipolar disorder. And so not coincidentally, the medications that can be used to treat a seizure are effective with bipolar disorder. Serendipitously discovered, this is what we learned. And then finally, the atypical antipsychotics, which have been out really in the last, since the mid-90s when they first really started coming out. Increasing research with them over the past 10 years. Some of them now FDA approved for the treatment of bipolar disorder. And also they can tend to be a little bit easier to tolerate than lithium or Depakote in terms of those side effects that they can bring. So in many ways, more and more of these are being used as first choice with bipolar disorder. Clozaril, some of you may be familiar with that one. It's what is known as a good treatment-resistant medication. If other meds don't work, oftentimes Clozaril is the one that works, sometimes called the gold standard. So if you've been having trouble and haven't tried Clozaril, it might be a good one to talk to your doctor about. And then Lamictal, which I touched on before, just want to mention that one. First FDA-approved medication for bipolar disorder, effective for both acute depression and long-term maintenance of the disorder. And again, it's not going to be effective in treating mania. And also one of the things that when the person first starts taking it is you need to monitor for a potentially serious skin rash. It's something that if noticed and seen the doctor, taken off the medication, it does go away. But we do want to be very careful as we first start that medication to keep an eye out for that. A lot of research looks at, okay, well, which one do we start with? Where do we go? Is it just a free-for-all here? And there are logarithms, as they're known by, kind of like decision trees. Try this, then try that, then try that. And what our best decision trees now will tell us will be to try lithium, Depakote, or the atypical antipsychotic. If they don't work, we're going to try another one. And then we might go to a combination of the two. So we're going to keep trying. There's going to be a lot of trial and error when it comes to choosing medications. With, again, bipolar 1, if there is significant depression, we're going to be looking at that combination, perhaps, of lithium, Depakote, atypical antipsychotic with Lamictal. In bipolar 2, sometimes we may just see Lamictal, meaning that the person may not be experiencing significant manic symptoms or episodes. So from a medication standpoint, we don't necessarily need to treat that. All of it case by case. So I just wanted to kind of put this out there just to give you some general ideas of what are some of the most common medications that are being used right now. And again, to remind you that the polypharmacy is the norm. So if there is significant depression, folks with bipolar disorder can take some of those antidepressant medications, again, in conjunction with their, say, lithium or Depakote. With significant psychosis, they'll be taking antipsychotic. Again, advantage of using some of the newer antipsychotics is that you can deal with both the mania and the psychosis with the one medication. So it's a really nice advantage that we didn't have back when it was just either lithium or Depakote as our only two choices. And then for anxiety, we might have some other medications that we use for more acute anxiety. The most common of these are what are known as the benzodiazepines. And the caution with the benzodiazepines is they are, of all the medications I've talked about, they are the only ones that can become addictive. And so, remember we said last week, 2/3 of folks with this disorder are also probably dealing with a substance abuse disorder, some kind of addiction. So we want to be very mindful and careful if we start looking at these benzodiazepines in terms of helping to treat the acute anxiety. There will be very good meds for that. They're very good for panic, acute anxiety, treating it. We hopefully are not going to be on those medications for long periods of time. They're more the acute when I need it, as opposed to the ongoing maintenance, like all of the other ones that I've talked about. Then lastly, I just mentioned there were some newer anticonvulsants that came out a few years ago, Neurontin and Topamax. And again, initially it was thought they might be mood stabilizers, meaning helping to balance out the mood, manage the mania, like lithium or Depakote. Didn't really show the effectiveness for that, but they can be used for some additional things. Neurontin for mild anxiety. It's also used for chronic pain, so there's use for that one. And then Topamax can be good for mild depression. And unlike the vast majority of medications that we've talked about, one of its side effects is weight loss, not weight gain, which is always an attractive thing to hear when we're talking about medications. Because pretty much every other medication that I was talking about can bring some weight gain with it. So one of the things that we have to deal with. So I really want to focus mostly tonight on the what I'll call the psychosocial treatments, the interventions that we can do with folks beyond medication. And so as we move forward, we're going to look at the other three parts of this circle. And as a preface to that, I think it's important to recognize that bipolar disorder, I would consider a family illness, in that an episode of bipolar disorder is a trauma for the entire family. So while it is the person who experiences the symptoms of the disorder, it is the entire family that experiences the trauma. And so we need to keep this in mind when we're talking about good treatment, because the treatment will involve the entire family, and will especially involve you as family members doing things to take care of yourself as well. Because we know, like any other trauma, it leads to a state of disorganization or disequilibrium. The way things were working now has been thrust into chaos, and trauma does this. And when that disorganization hits, none of us are at our best. When we're in the midst of chaos, we're not at our best. We're not going to make our best decisions. We're not going to think through things as clearly as we would otherwise. So we want to recognize that. And so the goal essentially becomes trying to find that new state of equilibrium. Again, balance. And this comes out of the work of Michalowicz and Goldstein, a bipolar disorder family-focused treatment approach. They have a wonderful book for families and persons and families called The Bipolar Disorder Survival Guide, same authors. And so they really were at the forefront of incorporating families and providing an approach that works with families. And what they found, and this may resonate with you, is that the conflict they see generally boils down to two scenarios. Scenario one, the person perhaps embraces or over-identifies. They might say, well, I'm depressed and I'm unable to work. I can't do anything anymore. And a family may deny or under-identify. No, you're just being lazy and afraid. Get back out there. Or the other scenario, probably much more common in this audience, or much more common at a NAMI meeting, is when the person denies or under-identifies. I'm not irritable, I'm just an assertive person. I don't have bipolar disorder, it's just my personality. You have to get used to it. And the family embraces or perhaps over-identifies. They hear those things. Again, it's trauma, we react in trauma. No, you're getting sick again. Right, this is a problem. You need to take these meds. You need to talk to a doctor. You're getting sick. And so each of these scenarios lead to conflict. Right? We can be at that place where there's no way to resolve it if we're going to be fixed into these two positions. And so our work is going to be to try to first find a way to kind of indirectly deal with this and do so in a way that can engage person and family on the same page towards the goals that we are looking towards. Mikulowicz and Goldstein found that when they provided this treatment, in addition to medication, right, so it's meds plus this treatment, it significantly lowered the rates of relapse in their study down to 11% versus medication alone, where they saw a relapse rate of 61% over a 9-month follow-up period. So that's a pretty significant difference. 61% down to 11% by engaging the whole family and providing the right treatment for person and family that helps. Sure makes sense that we want to do this. So what are their goals? I'm going to list them here, and then I'm going to go through them in a little more detail. Number 1, integrate the experiences associated with the episodes of the disorder. Basically understanding, accepting this disorder. 2, accept the notion that the person is vulnerable to future relapses. Can't just learn from our mistakes here. It's a recurrent disorder, vulnerable to future relapses. Accept the need for dependence on medication for symptom control. Learn to distinguish between the personality and the disorder. What's the person, what's the disorder? How can we tell between the two? Recognize the significance of stress and learn new ways of coping. And then 6, reestablish healthy relationships with family, friends, right? Helping that person connect and communicate, get back out into the world. And as we do this, what are, again, the important concepts to keep in mind? We often hear about blame. Oftentimes when this hits, much like when anything hits in our life, we want to look, where can we put the blame? Because if we can put the blame somewhere, we feel better. It's their fault, it's your fault. I want to feel better. I can put the blame somewhere. So we're going to look to do that. We're going to look to do that. And when we do that here, we're really just going to shoot ourselves in the foot. Because we're not going to get anywhere. We're not going to get anywhere if we try and focus on blame. Focusing on blame is going to be looking into the past, which we know is not going to be helpful when it comes to just trying to attribute causality to it. Because we said causality is biological. So it's kind of hard to kind of blame our chemistry, right? or blame our genetics. We might try, but those things are what they are. Now, in past times, without our understanding of this disorder, blame went squarely on family. And number 1 source of that blame is mom. Mothers were blamed for pretty much every disorder that was out there. And so the worse the disorder, the worse the mom. What we've learned, certainly, is that when we talk about major mental illness with biological and genetic-based causality, that it doesn't make sense to start looking at what went wrong as the cause of this disorder. So folks with bipolar disorder can have just as good or bad moms as the rest of us. But we don't want to look for there as the cause of blame. So rather than think of blame, we want to get out of that loop. And so I like to think we want to focus more on responsibility. So when I think of responsibility, what I think of is that we're in the here and now, we're today. This is where it is at today. And we take responsibility for what can we do to help this, help treat this disorder? What can we do to go one step further tomorrow? As a person, as a family, as a caregiver, what can we do? How can we work together toward that end? It's very much of a more in the present and looking forward, as opposed to looking back and trying to attribute that blame. So that's going to underscore all of what we're talking about tonight. We talk about pursuing these goals. We talk about the right treatments. Right? We talked about balance. We talked about this idea of responsibility. And getting stuck on blame can be a real trap for us. So we want to just shift and steer away if we find the discussion going there. One of the other main forms of treatment that has been shown by research to be effective in the treatment of bipolar disorder is cognitive behavioral therapy. And cognitive behavioral therapy, initially developed by Beck for the treatment of depression. We certainly found now that it's very effective for bipolar disorder, for anxiety, for schizophrenia, many disorders. And in the research, we found that CBT reduces days in the hospital, produces better mood ratings, right, if we're looking at the mood, better social functioning, ability to cope with warning signs of the illness, ability to cope with the negative thinking that comes with the disorder, and help people kind of get back to work, back into life sooner. So we know it's going to be an effective treatment. What is it? What is CBT? Cognitive therapy really helps identify false, distorted, or maladaptive ways of thinking. So the essential thing to take away from this is that it focuses in on the thoughts and the thinking patterns. If any of us have watched any TV show that has shown a session of therapy, the first question that's always asked is, so how are you feeling? How do you feel? All right. That's the most common first question that we think of that therapy is about, right? How am I feeling? I talk about my feelings. And while feelings are certainly important, from a CBT perspective, I'm going to be more curious about what are you thinking? What are the beliefs behind what's going on? Yes, your feelings are going to come into play with that and as part of it, but I'm looking at your thoughts as being what are going to lead to the feelings. So we're starting at that place. And if we can identify ways that that thinking or those beliefs are maladaptive, getting in the way, then we can try and develop some alternative ways, some alternative notions of how to think. Now, this may sound a little fancy, but it's been around for quite a long time. I tried to research it, and I think the first cognitive behavioral therapist was Epictetus, a philosopher in the 1st century BC, who said, men are not disturbed by things, but by the view which they take of them. That's what we're trying to say here with CBT. That it's not just what happens, it's the view which we take of it. A simple model of CBT is ABC. A being the activating event. What was the trigger? What happened? B, what's my belief about the event? And then C, what was my reaction? The feeling, the behavior that occurred. What typically happens, what we typically experience, is the jump from A to C. Something happens and I react. That car cut me off on the freeway. I had to chase him down. Right? I had to yell and scream at him. Right? I got angry. Right? As if it was instant. There's really a lot of thought process that actually occurs in there. If we slow it down, we would see that. Because, when that happens, I don't necessarily have to start chasing that person or get all angry with them. I might decide to let them go have their accident elsewhere. And have a calmer approach to it. So, a lot of times when we're doing this work, it's almost like we go in slow-mo a little bit. Or, as if we could freeze for a moment. What would be the thoughts that are going on with that? So we can take a look at them. Try and examine them. And then, again, if we can, develop some alternative ways of thinking about it. Because really the only things that go from A to C are reflexes. You go to the doctor, puts the hammer on your knee, and your leg kicks up, that's a reflex. There's no thought involved in that. By and large, the vast majority of things we experience in life, there are going to be a thought process in there, even if it's instantaneous. And so that's what we're going to be curious about. Can we get at that? And can we help the person with some more adaptive ways? So again, the 3 steps here: identifying the negative thought, identifying what we'll call the distortions inherent in those thoughts, and then substitute the more accurate, positive, realistic thought, which directly challenges the negative thought. Now these distortions, if you read a little about CBT or get any of the workbooks, what you'll see is a list of usually about 8 or 10 different types of distortions that we all do. However, in periods of depression or mania or anxiety, we'll tend to exaggerate them a little more. One of the most common ones that's going to be especially significant when we're talking about bipolar disorder is the distortion of what is called all or nothing thinking, or polarized thinking. We see things in black or white. It's always like this. Nobody likes me. This always happens to me. I'm never going to get another good job again. Right? The all or nothing thinking. This is just the way it happened. There's no gray area here about it. Our goal is going to be to help explore, is there some grayness? Now this may be very hard when someone is very fixed in that all or nothing thinking. But our first step might be just to kind of explore that. Oftentimes we use some of that kind of Socratic dialogue. We're just kind of posing questions and exploring. As opposed to saying, no, you're thinking wrong, think like this. We can't just tell the person, how many of us like to be told, no, it's just wrong the way you're thinking? How can we invite that in? Common things, we all do this. Let's just explore it a little bit. Another avenue to take is exploring how adaptive is it? How helpful is it? When you take that approach to something, does it help you? Whether it's right or wrong, it doesn't really matter if it's not going to be helpful. It's not going to be adaptive for you. What would be a different way maybe to approach this? That might be a little more adaptive for you. Might be a little more helpful. And so it might help guide the person in that direction to think about. Sometimes in exploring this, we might even take what we'll call the Columbo method. Some of you, I think, might remember Columbo. Right? Columbo, if you watch one of his mysteries, he's kind of bumbling around, and to everyone else, it looks like this is the most bumbling, ignorant guy. How could he ever solve anything? And then all of a sudden, at the end of the movie, it's like he puts it all together and he surprises them and he solves it. Because what Columbo does, he kind of takes that one down position. Yeah, I don't really understand. Can you help me understand this? I don't quite get this. Can you help me? And what is he doing? He's inviting the person to share more. And so sometimes with your relative, taking that kind of one down position, I just don't, I'm sorry, I'm just not able to get it. I know it makes sense to you. Can you help me understand? Help me understand what's going on. And being open to listening to that. Again, just ways of trying to invite out of that polarized place, the all or nothing thinking, and just into exploring what we'll call those shades of gray, other possibilities that might be present. So with some of these things as the backdrop, I want to go through the different goals and some of the things that we'll do to try to help promote movement in that direction. So goal number one I mentioned was integrating the experiences associated with episodes of bipolar disorder. And by this, what we mean is to really listen, to accept, and to understand. This goes back to something I said at the beginning of the last week. Take the knowledge you have, put it in your brain, but put it to the back for a moment, and then when you're with your relative, be with them and listen to their story. Hear their story. Hear their experience. That's the first thing we have to do. Learn the essential features that they experience of the disorder. What is it like for them? Their own subjective experience. This is how we can help engage the person. As person and family, acceptance can be a hard one. It can be a hard one. We might want to fight it. No one wants to accept having an illness like bipolar disorder. No one wants to just accept that, yeah, this is what we've got in our family. If it can be something else, we'll probably choose something else if we have a choice. But once we kind of see this is what it is, we've had episodes, been through a few hospitalizations, we've been to enough doctors, it's like, okay, this is what's going on, this is what it is. We have to accept it, even if the person doesn't. Again, we can't force it onto them to accept it. We can try some of these other things to engage them, at least in discussion around treatment. Again, recognize that blame is pointless when we're doing this. We're going to talk a lot about this idea that the person's vulnerable to future relapses, and talking about relapse and recovery. Because while we said families and the environment aren't the underlying cause of this disorder, we do know that family atmosphere and stressors and things that go on in the environment can trigger further episodes of the disorder or really promote recovery and help prevent episodes of the disorder. So we really want to hone in on this area when we're talking about relapse and recovery. And it's going to be common for the person, especially after that first episode in the young adult, to be like, I learned this won't happen again. The only reason this happens is because I took way too many classes last semester. I know not to do that again. I've learned from that. Recognize that when we're talking about this, it's not just about the medication. And we know medication is the foundation of treatment. But again, these stressors and what we do about them, a lot we're going to do here. And we might want to develop what's called a relapse prevention plan, which identifies warning signs and healthy behaviors. So this is often one of the first things I try to do with a person who I'm working with. And when we do this, and you all received a worksheet packet, and there's a copy of this handout in there. And what we're doing here is two things. We're identifying the warning signs of the disorder. Now, important to remember that warning signs will be unique to your relative. They're going to be unique to the person. And so while we might take a bigger list of common warning signs, we need to be able to then try and narrow it down, hone it down. Ideally with the person and family, sometimes it might be just one or the other. But we create that list of perhaps 5 or 6 things. So as opposed to having to keep in mind every symptom you've been hearing about with this disorder, you have a nutshell of 5 or 6 things that this is what happens every time the person goes downhill. This is what happens before hospitalization. So we're worried. This is what happens. And so if we recognize that, it's the invitation that, this is when we know to take some action, to be able to take some action with it. With bipolar disorder, it may be necessary at times, if the depression and the mania are both significant, that we have different lists for each of those. What are the warning signs of mania? What are the warning signs of depression? So bipolar disorder is a little bit cruel in that way. Pretty much any other disorder, it's kind of one directional. We go from healthy to more of an unhealthy place. So there's going to be one set of warning signs. I get really anxious. I get really depressed. Psychosis comes on. With bipolar disorder, again, it could be I get really depressed, I get really manic. Maybe 2 different sets of lists we're looking at. Now the other component of this, which is very important and often gets overlooked, is the healthy activities. And so if someone's coming out of, let's say they're coming out of the hospital, I don't think we want to just invite them to sit home all day and monitor their warning signs. It's not much of a life. And by and large, they probably don't really want to do that either. They want to get back out into the swing of life. And so what we want to do is identify the healthy activities for them. And again, it's going to be different for each person. So we might start with a real broad list, brainstorm, and then we're going to hone it down and perhaps again develop 5 or 6 things that we want to start with. And know that these are going to be good things for the person to do each day. Things like exercise, getting out, talking to a support person. Maybe it's writing in a journal. Maybe they do yoga. Perhaps it's prayer. Perhaps going to a support group. Lots and lots of different possibilities. Identify what might work for the person. If you are in a situation where your relative wants nothing to do with this disorder, nothing to do with any of this stuff, perhaps this is something that you can keep in mind. And maybe you can remember, okay, what are those warning signs? What would be just the healthy things I want to encourage? Because by and large, when we're talking about the healthy activities, we're just talking about the stuff of everyday life. And so if we're dealing with someone who doesn't want to talk about illness, the healthy activities are just, again, those things of everyday life. Right? We talk about exercise with our friends. We might talk about doing artistic activities, or writing, or cooking, all of those things. Things we might talk about with anyone, getting out and doing things with friends. And so it invites us to have, if you will, more kind of normal conversations that they will be more open to having. And so you can keep this stuff in mind as you're working with your relative. So sometimes I just like to call this the recovery promotion plan as opposed to relapse prevention, because it really does help take those steps back forward. Another tool that's in your worksheet packet is known as a mood log. And another empowering tool for persons in that we're trying to help them understand their own experience of the disorder. And so what we would do is just invite the person to kind of rate their mood on a daily basis. Plot it on the chart. Are they in a healthy zone? Are they going up into a mania? Feeling more depressed? Where are they? And over time, we can start to see patterns. Or you might start to understand patterns. And you might see, do we experience, oh boy, lots of manias? You into those manias and down to depression? Are we getting that rapid cycling where it just seems to go back and forth really quickly? Are we dealing with depression predominantly? So that's what we're looking at most of the time. Again, this tool and the previous one, what's really nice about them is they can be very empowering. The experience of the disorder can be so unpredictable. What's happening next with this? And tools like this can be empowering in helping to know, these are the things that might be coming next. Here's some things we can do about it. Here's how my moods tend to go. And if I know that, I can know what to do about it. So empowering tools when we're talking about dealing with this and not feel like we're at the whim of stress, or at the whim of where life may lead. And then last, I just want to mention in this work, when we're trying to help someone, let's say, recover out of hospitalization, or wherever they're at, trying to move forward. Think about it sort of like kind of coming back up a hill, climbing back up and climbing back out. And one of those popular adages in our culture is, if you fall off the horse, just jump back on. And I want to be careful because it's a great thing for many things in life, but not when it comes to dealing with an episode. Because we know it's going to take time to build back up. And so I often will use the analogy, and any of you sports fans would know what the term injured reserve is. The injured reserve list. The injured reserve list is the one where athletes, team athletes, are put on a list where they're not able to play because of injury. And when they're on injured reserve, they have to go through a period of rehab. So, knock wood, this doesn't happen again, but let's say Kobe Bryant injures his knee. He injures his knee and he can't play. Does Kobe Bryant become a bad athlete? Is he all of a sudden now just some disabled guy who can't do anything? No. He's still the same great athlete. However, what he needs to do is to gradually rehab from his injury. And so the first thing he does is probably use crutches, and he might just have to use those for a while before he can do anything in the gym. Then maybe he starts working with the physical therapist, and he starts doing some light exercise. In the news, I think a month ago, I saw him running in some kind of chamber which kind of takes the effects of gravity away, so it took the pressure off his legs when he's trying to recover. So he's doing all these things to try and recover. Gradually he'll start shooting. Gradually he'll start playing lightly on the court, and then much later he'll be on the court in the game, and probably not even playing the whole game that first time out. So gradually it's little by little. And the analogy really makes sense because he comes back too fast, he re-injures himself. Now the advantage of using a story like this is we all look and say, wow, he's one of the greatest athletes in the world. And he has to take it one step at a time in his recovery. So, okay, it's not a weakness that I have to do this. It's not a weakness when we start talking about doing one step at a time. Or we say, let's not just go back in and take a full load of classes right away. Let's build back up to that. let's take a class first, or one. Maybe take some time before we even get there. So build it step by step. Step by step is really going to be our mantra in that recovery process. Knowing that, right, like all of us, what we want it to happen yesterday. We want it to happen quickly. But we're going to try and do it step by step. So lots of different ways we can approach relapse and recovery, recognizing again that there's this vulnerability for that. So what I'd like to do before mentioning the other ones is take a break. We're going to take about a 10-minute break, and then we'll come back for the second part of our lecture and our wonderful guest speaker. Okay, we're going to get started, and I'm going to speak for about another 10 minutes, and then I'll invite Aaron up to speak. So moving forward, next goal I want to mention is this notion of accepting the need for dependence on medication for symptom control. Something I know that many of you maybe are or have struggled with. And again, it's this idea that nobody really likes to be dependent. And Jeremy here is going to illustrate this for us. Jeremy's your typical 15-year-old hanging out in his room with his friends, and mom comes on in and says, "Jeremy, how would you and your friends like some snickerdoodles?" "Oh, feel free to embarrass me anytime, Mom." "All I did was ask if you wanted some cookies. What's wrong with that?" "I guess it isn't what you said, it's kind of how you said it." "Well, I said it in a perfectly polite way." "Okay, it isn't how you said it, it's that you sort of exist." Poor mom gets it. Now I imagine most of you moms can probably resonate with that one pretty strongly, no matter what you do and how you do it. With medication, it can be that same way. None of us like to feel we're dependent. Teenagers don't like to feel dependent on parents. The idea of going back on medication, this disorder, can often bring about states of dependence again that we wanted to get away from in adolescence or young adulthood. I have to be dependent on a pill. No one wants to feel dependent on a pill. Or perhaps the person was starting to be in school or work or be independent. And now as a result of the illness, they're back in a more dependent position upon you as the family. For the roof over their head, finances, you name it. And so it brings about those natural struggles that are going to happen when we kind of go back into that dependent position. And so knowing that this is going to be there, it might help us to remember to try and stay out of those power struggles as best we can. To try not to make it I have to convince you to do this, or I have to kind of hold it over you. As little as possible, we want to do that. Sometimes we will set some limits, and that's when we find necessary points. But as much as we can avoid that kind of power struggle that will happen in adolescence, the better. One way in addressing that is to use friends, family members, whoever it is that your relative will listen to. And perhaps they become someone who talks a little bit more with your relative than you do, if it's not you in that situation. Perhaps they can talk to them about something that if you try to do it, it'll be like poor Jeremy here and his mom, where no matter how you say it, it's just not gonna go over. So again, this idea that medication is going to be important for managing symptoms. Goal 4, learn to distinguish between the personality and the disorder. Is this you or is this your illness? The idea here is when a person is at their baseline, their balance point, what are they like? What is their personality like? So oftentimes folks with the disorder have kind of just a higher baseline of energy. If you've ever seen Carrie Fisher speak, when she gives a talk, she's going extremely fast. She makes lots of connections. She's very humorous. She talks openly about dealing with her disorder. And you might look and think, oh my gosh, she's manic. But at those points, that is her baseline. That's not her mania. And so it's learning that this is her personality, is like this. We all have a unique personality. So your relative with this disorder has their own personality, and we want to be careful not to attribute the things that might be part of that personality and make them symptoms of the disorder. Because if we do that, we're going to be always accusing them of having symptoms. The disorder exacerbates the personality. If someone is assertive, if someone is stubborn, they were like this long before the disorder hit. The disorder is just going to make it worse. It's not going to be the cause of that, right? We got to remember, like, they had this personality before this thing hit. The disorder now, it just exacerbates it. It exacerbates it. Look for a pattern, not a single symptom. So that relapse prevention plan, when we were looking at warning signs, what helps here is recognizing that it's going to be a pattern of things that tell us when it's more the illness or the disorder that's happening. What I mean by that? When your relative has a bad night of sleep, we don't want to set off the red alert and think, uh-oh, you're having a manic episode again. We can all have a bad night of sleep. If poor sleep is one of those warning signs, and now you've got a few bad nights of sleep, along with perhaps a couple other warning signs, now you're seeing this pattern develop. And that's a different message. And hopefully, at least when we see that, we start with a yellow alert before we get a red alert to see, okay, what are some things we can do to try and manage this. And hopefully we can build in some tools and things we can do before we even need to call the doctor or change meds or things like that. And so here again, when we see patterns, it helps us. It helps the person because that way they won't feel like, they have to be perfect and they're on edge all the time. Maybe it helps you as a family to feel like, okay, wait, I can take a breath here. It's just one symptom on one day, not the other 5 and not over several days. When I get the pattern, then I start taking action on it. Again, note that if I'm really vigilant, I'm too vigilant on this, I'm going to promote more distance from the person. Again, if they see me as like, gosh, every time I breathe wrong, you're on me, then they're not going to want to show you when they start breathing wrong. Or much worse, when they start having some racing thoughts or start feeling depressed again. They're not going to want to show you that. So goal number 5 is recognize the significance of stress and learn new coping strategies. And there's the 4, what I call the super sensitivities. They're all S's, the 4 S's that we want to keep in mind here when we're talking about the impact of stress. Number 1, substances. Anything we put in the body, any substance we put in the body is going to affect the body. And so while the first thing that jumps out at us here would be alcohol and drugs, and that's certainly going to be probably the most dangerous thing we're talking about here, we want to be mindful of other things as well. Sugar, caffeine, how do they affect us? How do they do it? Okay, milder, but again, being aware. What is it I'm putting in my body? How does it affect me? That's number 2, stress, stress management. The simple thing here is to avoid the stressors that we can avoid, and then identify the coping strategies to deal with the rest. Whether it's those healthy behaviors or, again, just specific strategies based on the stressor that we want to help the person learn. S number 3 is structure. This is one of those ones that's helpful for all of us. How many of us have our calendars on our computer or on our smartphone? We have our appointments, we know what's going on. Our day is structured in that way, and it helps. I know from my kids just went back to school, and I'm really grateful for having that structure back. For me, more so than for them. For me, it kind of gets me back on track a little bit. Summer always throws it off a little bit. So structure's good. With bipolar disorder, it's going to be especially important. Again, right, we're talking about this disorder of extremes and swinging, highs and lows, the importance of the sleep-wake cycle. So having some structure in there to balance is going to be important. One of the tools in your packet, right, activity scheduling. This looks like the calendar we might all see on our desktop or on our smartphone. How do we schedule our time? Now, our goal here is not to fill this up. depending on where we're at. If we're talking about day one out of the hospital, it might mean, let me put one thing a day, maybe a couple things on there a day, no more. I take a walk in the morning, I go over and visit my cousin in the afternoon. It's enough. But I'm starting to structure some things in there. And then gradually we'll increase that. There'll be more and more structure there, more and more activities that we'll schedule in there. One of the things that can be helpful, and this is especially helpful with depression, is to have the person predict 0 to 10. How satisfying do you think it's going to be to go out and take that walk? When we're in that depressed place, nothing looks good. And so, it'll be a 2. It's not going to be that nice. Afterwards, let's re-rate that. Oh, it actually was pretty good. I'll give it a 6. Right? It's a big difference from a 2 to a 6. What we see is that, again, when we're in that, especially on the depressed side, when we're in that space, it's like we're looking through that dark lens. When we look at the world through a dark lens, nothing's going to look too bright. Nothing's going to look too satisfying and enjoyable. But just by engaging in the activity, going back and looking at, okay, yeah, it was a little better than I thought. Maybe just a little more oomph, a little more motivation to try and do it the next time. As a family member, maybe you highlight that. Don't have a parade, but just point out, wow, I noticed that, you look a little more brighter. Wow, that was a pretty nice walk, wasn't it? Just something like that just kind of mirrors back that you're seeing something a little different there as well. So, structure. Structure here we're talking about. The 4th S is support. It's so important to have good support. Family, friends, support groups. I like to think that both as for individuals and for families, you need to have your, what I'll call more your treatment type supports. So for the person, maybe it is their peer group. If it's the DBSA, the Depression and Bipolar Support Alliance, has wonderful support groups for folks with depression and bipolar disorder. Maybe it's the group at their clinic they go to. Some connections that way. But also it's nice to have some other supports that are totally unrelated to the disorder. So again, their life isn't just all about their disorder. Maybe it's other friends they've had, or friends through school, or just through activities or sporting events that they like to do. They have friends they connect with through there. As families, I'll invite the same thing, and I'll talk about this in the last week when I talk about you as the family and the importance of taking care of yourself. That, go to your NAMI group and get your support for dealing with the illness, but then also go out and do your other things. Get your supports elsewhere as well so that you also are having a good life. And you're modeling for your relative when you do that. So know that you're modeling for them the importance of going out there and getting good support. I'll just mention them. Again, the Depression and Bipolar Support Alliance, DBSA, their number and website here. Again, advocacy, support, education for folks with these disorders, and local support groups that folks can connect right in with. And then, of course, by now I hope you're familiar with NAMI. If not, you're going to hear about it a lot over these next several weeks, with the importance for you as family members, especially for getting connected with NAMI for education and support. And what I'd like to do is I'd like to pause here. In the final week of the series, when I talk all about helpful family roles and skills, I'll probably hit on what that last goal is, which is talking about good, healthy communication. So I'm going to hit on that more there. It's there as the 6th goal in your handout tonight that Miklowitz and Goldstein talk about with bipolar disorder, but we certainly want to talk about it with all disorders. So I'm going to come back on that in week 6. And so I'd like to really pause now to invite what I think is probably going to be the highlight of this evening. And that is, I'm going to invite Erin to come forth. And Erin is going to share a little bit about her story. And I'm grateful to Erin. She's been here for I don't know how many years she's come out of good gratefulness. of her heart to do this.
Yeah, I don't know why you keep asking me here, but since you do, I keep coming.
If she keeps coming, I'm going to keep asking. She's really great. So she's going to share about her story, and then afterwards we'll both be up, take questions from her. So
cool.
Please welcome Erin.
So I'm assuming you guys are all here because you have family members or loved ones that are suffering with bipolar disorder. Maybe yourself too, I don't know. I know I have people I love with bipolar disorder along with myself, so it's great that you're here. I really applaud your efforts, and I really think it makes a big difference when you come to these things and learn about what's going on, so thank you for being here. I really want to tell as many things that are like going to be relevant to as many people as possible, so I don't want to get too much into my personal things, but I'm happy to answer anything. But for me, I was first diagnosed with bipolar disorder when I was 25. I was having some extreme delusions. I thought I was going to be the mother of the next Christ child, and and I thought I was supposed to form like my tribe, the tribe of all tribes. And so I was seeking people out, and I had these missions in my mind, and that was like that was like, okay, so that happened. But before even all of that happened, I had lots of depressions when I was younger. The first time I had a major depression, I was probably 13 years old, and I first started thinking about suicide when I was about 13. I always had a hard time getting along with people. I don't know, I kind of have a social anxiety thing going on as well as the bipolar. I don't know if it's which came first, maybe the bipolar and then the social anxiety, but dealing with people has always been one of the hardest things in my life. Just like, this is cool, I don't mind standing up here and talking to you guys, but if we're at a party and I have to like mill around and kind of like make small talk and say, hey, how's it going? Oh my God, it's like the worst nightmare for me. I mean, if you want to talk about like the most painful part of your life, I'm there. Like, let's talk about it, you know? Or like what the meaning of life is, let's talk about it, you know? But if it's just like, okay, so what'd you do this weekend? And hey, do you have some friends that you want to go to the park with? It's like, oh no, I can't do that. So, and I think a lot of that comes from having so many extreme experiences, you know? It is kind of hard to talk with someone casually when you've been thinking about killing yourself, you know? It's like, okay, yeah, like I've been seriously thinking about killing myself, and they're like, so, how's it going? I'm like, great, it's going great, you know? So yeah, so I'm gonna get into that, but you know, I've been kind of an overachiever, part of it from my upbringing. I also have I'm dually diagnosed, so I have an addiction to pot and also to everything else. I have an addictive personality, and so that makes me dually diagnosed. I've got bipolar disorder and I have an addiction disorder. So that's what that means. And it's actually really, 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 really common. My experience, or what I think I've been taught, is like 70% of people with mood disorders have some kind of addiction. It makes sense, you're trying to treat it, you know, it feels awful, and you want to do whatever you can to feel better. And if that means smoking some pot because it seems like it solves the problem, then by all means, you know. And if it solved the problem, I would tell everyone to do that. You know, I would say, go out, you know, smoke as much pot as you can, you know, but it doesn't solve the problem. I have a chemical imbalance, and pot is not the chemical that will solve my imbalance. I have to get medications for that actually solve my imbalance. And so, so that's just the practicality of it all. So, let's see. So you know, I went to college, I got diagnosed with this mood disorder, and I had a huge melting point. And at this point, I had been in a violent relationship. I was around really dangerous and crazy, sorry to use the word crazy, dangerous people, dangerous people. My choices had led me to a really dangerous place. And at that point, I was very disconnected with my parents and disconnected with my friends. I really, at that point, had no one. I had no friends, and the only people I was talking to were people that were not, like I said, dangerous. So I ended up calling my parents up and asking them if I could come and move back home. So, of course they said yes. So here I was moving back home. I had been away from home for about 10 years. My parents and I were not close growing up. And all of a sudden, I'm like in the middle of a mood disorder problem, addiction problems. I have no friends going on, and I have no connections to anybody. And it was just a nightmare, a huge nightmare. I'm very grateful to my father. I have a father who has a way of communicating that is just gentle enough to show me that he's caring. Actually, it's just pure gentle. Let me just say it like that, okay? It's pure gentle, okay? It's like, oh my gosh, I can see that you're in so much pain. What can I do to help? Like statements like that, and like really believing it, and really saying that to me. And because, the mind of someone who's bipolar, I can speak for just myself, but when I'm in that place where I feel so disconnected and I'm thinking all these random thoughts that no one is understanding, and it just, and everything just feels so awful. I mean, I want to die. I really want to die. And when I say that, you guys, I mean, just trust me that if there's someone in your life that's feeling that way, it's really serious. And it's really serious, especially if you have bipolar disorder, because we have these really quick reactions. So if we're feeling really awful and we're gonna think about killing ourselves, then we might really quickly go and do it. And I mean, I'm so grateful to the people that have saved me from that, because there were many occasions where I was on the edge of killing myself. So, let's see. I've been hospitalized 4 times. And each time was because I wanted to kill myself. One time I went to Los Encinas, and I thought we were just gonna like say hi to people. They're like, come on in, like let's talk, And I talked to them for like 5 minutes, and then they all stood up, and they walked outside like right next to me, and I'm like, what is happening, And they told my parents, like, she's not going home. Like, what? What are you talking about, And here I am, this like, you see me now, and maybe, I don't know what kind of impression you get of me, but if you saw me at the height of one of my mood episodes, you would be scared, okay? I mean, honestly, you'd be terrified, And I to this day I feel bad for all the stuff I've done to my parents. I mean, I locked made my parents captive in their own house one time, and like destroyed all these things. Took their nice artwork and threw it down the hill and stuff, and just did all kinds of things in those moments of not having any tools, having all those emotional crazy things going on and not having any tools. So, so a few wonderful things have happened that have kind of helped me to kind of come back. When I went to Los Encinas that time, I met my therapist there, and he is still my therapist. I've had him for about 12 years. And he actually said this to me just about a week ago. He's like, because honestly, I was ready to be homeless. Like, I thought living in regular society was way too hard for me, and I wasn't gonna be able to do it, and I would prefer not to think about anything or worry about anything and just be homeless. And when he first met me, had he not been the kind of person to really like try to figure out, who I was and the potential of who I was, he could have just dismissed me as this like really, crazy person who wasn't gonna get better. But for whatever reason, he saw something in me, and he was willing to he even told me, he's like, I didn't believe anything you said when I first started seeing you. Like, really? He's like, no, I thought you were totally making stories up. Like, I wasn't making it up. I wasn't making it up. So, so anyway, so that first relationship with him, someone who I respected. You know, it can't be any therapist. It has to be someone that you respect, you know, and someone that you trust. And I trust him and I respect him, and I felt that way from the beginning. And I've been with him, you know, for 12 years now. So another really good thing that happened was that I did decide to go to a 12-step meeting. Like I said, I smoked pot all the time, every day. People would hand me pot. Please smoke pot. Like, they would say that to me, you know? Like, I'd come home from work, here's some pot, you know? Smoke some pot, please. I'm like, okay. You know, and, you know, believe it or not, people think pot is not a big deal, you know? And for some people, it's not. But if you're an addict and you use it addictively, it's a problem. And for me, it was a problem, and I used it every day, and I even engaged in all these kinds of promiscuous activities that were very dangerous, and you know, all kinds of stuff from pot. So at some point, I finally realized, oh yeah, I was hospitalized again. That's what it was. Hospitalization, nothing like getting locked up to give you some fresh eyes. By the way, if you have a loved one that you really believe is going to kill themselves, please call and get them in a hospital. I know it's not what they want to do. They will probably hate you for a while. They will probably talk badly to you for a while, but you know what? They'll be alive to do it. So, you know what? Hospitalizations are necessary sometimes to find the right medications and to get back on your track, okay? So, this last time, I talked to the doctor there, and he was, I don't know, he's from Europe or something, and I thought everyone from Europe smokes pot. So when he said to me, you know, he said, I don't know what's with you Americans, you think that pot is just fine. What makes you think that? You need to stop smoking pot, just stop. Stop smoking pot, you know? And the way he said it to me was just like, it kind of hit me in the head for some reason, right timing, and I decided to go to a Marijuana Anonymous meeting. Actually, I met that guy over there, my very first day, which I'll get to, but how are we doing? Am I okay? Okay. I brought my meds up here not as a demonstration, but because I have to take my meds at the exact same time every day, and if I don't, I get off schedule. And my schedule is really, really important. Like super important. Like that's probably the number one thing. Taking my meds at the same time every night, which of course I take a lot of Seroquel and it knocks me out. So which means I go to sleep at the same time every night, which means I get sleep every night. I get a lot of sleep every night. I need 9 hours of sleep. 9 hours of sleep. And I give that to myself because it is the number one thing for my recovery. So I'm going to take those in just a little bit, but I'm going to keep talking for a little bit longer. It takes about an hour to kick in. So I went to Marijuana Anonymous, and in the program, I learned some tools. Some tools. I started having some tools. I think the support network is probably number one. You know, I had my therapist now, and I did have my father who was always kind of supportive. And when I started the 12-step program, I started to meet some people as well, and I started to develop a support system with them. It was very hard for me though, I have to be honest. It was very, very hard at the beginning. Someone told me I had a fuck you igloo when I first was sitting down, like, don't fucking talk to me. But it wasn't because I'm like mean in person and I was gonna hurt you or anything. It was just like, I thought so badly of myself, you know? My impression of myself was so low. And it can still be low, and I have to keep, and I can get triggered because all these years, that's just something I wanted to say, all these years of experiences with dangerous people, with being rejected by friends, you know, over and over again, you know, by being law issues and sex issues and all this stuff where it's traumatic stuff, not just like normal interactions, like traumatic, you know, painful, horrible, you know. That stuff is really, it's, how do I put it? It's just, it's something that I just always need to appreciate, that that's what I've been through. You know, I have been through some serious trauma. And if I struggle from time to time, if I, forget my worth and I start to doubt myself, that's okay, because I'm gonna come back and I'm gonna be okay. But I've been through a lot of trauma, and most people who have a mood disorder have been through a lot of trauma. So the 12-step program has been awesome. I got a sponsor, that kind of thing. Sponsors was great, really great. And they talk about tools through 12-step programs, just like tools, 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 tools. They tell you all kinds of things. Like they've got sayings on the walls, they've got books to read, they've got all kinds of really nifty expressions that kind of like sit in your head when you're not realizing it. What is it? Expectations are the beginnings of resentments, or how does it go? Do you know?
Pathway to disappointment.
Oh, pathway to disappointment. There you go. That works too. I've learned that expectations is a really dangerous place for me to go. If I start to think that, you owe me something, or, when I go to this place, it's going to be like this, or how come she gets this, and how come I get this, and how come, all these kinds of things, expectations, it's like, it does not help me. It does not keep me a safe, peaceful person. And just doing the steps, like I've been doing the step work and making amends and apologizing and building relationships back and all that kind of good stuff. So, at this point, like, my life is pretty good. I'm also a teacher. I'm a teacher. And luckily, it was partly because of my family. My parents were teachers, and they were able to get me a teacher's assistant job. So once I did that, then I realized there was this intern program, and I did this I can't even believe I did all of this stuff, but my parents are very, very convincing. So I became a teacher, and even with all the pot, I'm still a teacher, and even with all the promiscuity and all this stuff, I somehow maintained my job. But even though, which is great. And I have lots of friends who have bipolar disorder who are not able to maintain regular hour jobs. And, that's totally fine. The worst part about it is the stigma and the feeling of being less than. So, all I can say is for people who, like, I have a sponsee, and she's also dually diagnosed, and so she has a part-time job, and I'm just like so amazed with all the things that she does do, with the med compliance, with the family relations, with the, just all these different things that she's doing, and it's great. It's amazing. So I do have all these wonderful things in my life. I have this job, and I have my husband now, almost 2 years, coming in a week. And things are really good, But I just, last time I was here, I was actually lowering my medication because I was thinking about getting pregnant. And so I had lowered my medication, and the journey of finding the right medication is like very, very painful also, and to lower medication is like a big, huge, crazy thing too. So I was like doing it slowly, and it was really hard, and I thought I could do it, and then I had this like big breakup with a friend, and that was enough to like trigger this hardcore depression, suicidal like episode. So, like, as much as I seem like everything's fine, I have to always remember that if I don't keep my med compliance, and by the way, I ended up going back to the psychiatrist that found the right meds in the first place, because different psychiatrists will prescribe different medications. And unfortunately, the one that I went to happens to be a very expensive, pay out of pocket psychiatrist, and I've seen him a few times, enough to have him help me find the right cocktail. But it was amazing, from lowering the medication, having this suicidal episode, and then going back to the regular medication again, all of a sudden I was like, okay, I'm gonna be okay. And it's crazy that medication can do that, And it's hard, especially for young ones. My nephew, he's 18, and he's diagnosed with bipolar disorder, and the last thing he wants to do is take medication every day. But he keeps seeing what happens when he doesn't take it. And when he doesn't take it, he's a mess. he's, having panic attacks, and he's, like punching walls, and he's, all over the place. So he has finally come to the place where he wants to take his medication. So let's hope he stays there, and I think that's pretty much all I have for now. Is that enough? Okay, thank you.
Thank you.
Yeah.
Well, let's open up for questions for either Erin or myself, and we'll be happy to entertain you.
When you're actually in an episode, are you aware of it?
You mean like the depression, the suicidal depression, you mean?
I was actually thinking more of a manic, but
For
So
me,
let me, I'm just going to repeat the question so everyone can hear them. The question is, when Erin's in an episode, is she aware of it? Does she know what's happening?
that's sort of like been my life's mission, is to kind of gain more awareness of myself. So now I'm a little bit better. Like I'll notice my speech happening faster, and I'll notice I'm doing a lot. I've started 20 projects and I haven't even thought to complete one of them, and I start to notice it more. But it's hard to notice it.
and when you notice it, what do you say to yourself?
I take deep breaths, I try to slow down my speech. I say I'm focusing on this project,
So you're saying it's hard to
Oh
notice
yeah, I forgot to mention my favorite tool of all. Oh my gosh. My favorite tool of all is meditation. And that's what saved me from this most recent suicidal binge. It was the medication and it was the meditation. And I do it every single day. And I do the Deepak Chopra ones, the ones that he like guides you through and gives you mantras and all that kind of good stuff. Because it gives me that moment of pause, of, thinking about what's happening. So, yeah.
And what about when you're more in a manic place? Do you, like you talked about, your parents' house throwing their artwork around, stuff like that? Is there some internal voice saying something?
Not then. Not then. It's like little by little. It's like a gradual increase. It's not.
Does it happen like right after the destruction, so to speak?
No. Usually there's shame after that. It's really a deep, complex process. It usually is like, like I said, going into a 12-step program and doing healing by doing steps and making amends. It's like this deep thing to get out of it. Yeah.
So just to kind of tie it back into what I was saying earlier about this idea of warning signs, what Erin was just describing is that she knows what those warning signs are. And if they start to increase, she has tools she uses to then manage. If she doesn't do any of the tools, and those things just keep increasing, at some point then the awareness goes, and you just got to deal with the consequences that come with it.
Did you have, when you decided to start recovery, did you do that on your own, or did you have people influencing you, or helping you to realize there's a problem and you need to?
So the question is, when Erin first started her recovery, did she do it on her own? Did other people kind of help her realize? How did that happen?
I kind of had to come to it. I mean, like I said, I was in the hospital and there was a doctor who kind of made it sit, but I had to come to it. If people, people tried. They're like, oh, stop smoking. I was like, shut. Yeah, I didn't want to hear it. Yeah, unfortunately. Sorry.
At NAMI meetings, I hear people talk about how the psychiatrist is prescribing a drug and the patient is not doing well or is getting worse. How do you know when you should switch psychiatrists?
Great question. How do you know if you should switch
That's for you.
psychiatrists? That's for me. I'll answer, and then if
Okay.
maybe you've been through switching psychiatrists. I don't know. It's important, like we said, to know there is some trial and error that comes with this. I mean, if you're having error after error after error, maybe it's saying we need to look at that. The other thing, and this is where NAMI is helpful, is in knowing, is the psychiatrist somebody who is kind of well-versed in the area of dealing with, fill in the blank of what your disorder is. If it's bipolar disorder, is this somebody who's kind of well-versed in that area? Or not? And that might be one way to know. And then find someone who is kind of well-versed in this area. The hard part is that, for some folks, lots of different medications don't work. They're kind of treatment resistant. And there's no way to know that other than through that trial and error. But if the other thing too is if, you're really seeing struggles and the psychiatrist is just saying, well, this is just, it's not going to get any better, this is as good as it gets. that might be another thing, like, well, let me see a consult at least elsewhere, and see if there are some other options maybe that this person's not aware of. Anything you would?
Yeah, yeah. All I know is that when I'm taking the right medications, I know people say it takes 4 to 6 weeks or 6 to 8 weeks, but I know for me it's hit me a lot earlier than that. And I really, really can tell that it's working. I've always been able to just tell that it's working. Like I've taken medicines that were wrong and they knocked me asleep like in the middle of the day. That was wrong, like done with that one, you know, move to the next. But yeah, someone who's well informed also, like the doctor I went to, he knew medications really, really well. He knew the way they interacted with each other really, really well. He was really knowledgeable. So you have to feel like they're knowledgeable, really knowledgeable. It's really important.
But isn't it a question of luck to get the
Sometimes.
right
Yeah.
drug?
Sometimes.
Yeah.
In some ways, there is some luck involved because it's trial and error. Again, the good doc will at least know how to improve the odds by knowing which ones we should start with.
I mean, like I'm on
So,
lithium,
absolutely.
you know, and usually you start with lithium, you see if lithium works. Maybe you don't start with lithium, I don't know.
One of the ones you start with,
Okay,
absolutely.
so-
Still do. Yeah.
Anyway.
I was going to comment too, especially if you have a therapist that you have a good connection with, a good rapport with. Sometimes the psychiatrist may not even have the good bedside manner. They're
Oh,
so
yeah.
scientific in the way that they, in their
Yeah.
profession.
They never have good bedside manner. What are you
Right.
talking about?
Yeah, but sometimes they're just not good, period. But
Yeah.
there are times when they are wonderful pharmacologists.
Yes.
But may not be wonderful in terms of connecting, and I think it's
Yes.
important to be able to
Oh my
recognize
God,
that.
they're so different.
So yeah, a good comment that sometimes the psychiatrist doesn't have the best bedside manner. They're not in that role like the therapist would be. So you have a good therapist like Erin talked about, she can connect with and talk to. And so oftentimes the therapist, they're going to be the one that you're talking to a lot more often. And you know, the old idea that, well, the psychiatrist is the one you go and you tell your problems to, well, isn't that way anymore. They're like many times, if they're in that role of just medication management, they're more like a technician. They're going to go in there and hone in on that. And if they're doing that well, then great, be grateful for that, and use the therapist to kind of deal with all the rest.
Have you ever had any problems with your mental health care costs? Like, have they ever been too high, or have you been able to manage it?
God, I hate that that's even a question that people have to worry about, but it's like such a huge problem. It's actually the reason I became a teacher. I didn't become a teacher to help the kids. But I became a teacher because I wanted health care. And because they had a group health care policy, I was able to get it. Because I tried to get health care before and I wasn't able to get health care. I was denied. And when my medications are like thousands of dollars each month. Yeah, but I'm covered.
I want to ask you if you went, I have two like you, and I always went to the doctor with them, always, the first or the second time. And I asked them if they like it or not. And they never had the same doctor, because one like this one and one like that one. And they have to choose. Because if you don't feel really good and comfortable with a psychiatrist, it's not going to work. It's not going to work.
So just to kind of repeat, the comment there was that it's important that the person can at least feel comfortable with the psychiatrist. Just mentioning how she has 2 children, they each kind of like a different person. So they end up seeing different psychiatrists. So you want to at least feel like you have that connection where you can talk to them and just be open about what's going on so you can get the right medications.
Yeah.
Yes.
Do you ever feel or felt like you had demons inside of you?
Question is if Erin ever felt like she had demons inside of her.
Yeah, I wouldn't exactly use the word demon, but I definitely, there were times where I had sort of a, what do you call it? Some kind of complex. Basically, I thought I was like the scum of the earth, like awful, evil, like people were gonna see me and throw rocks at me.
Along the same lines with her question, are there any options out there for people who have no job, no money, no means to get the help and to get the medication?
Yeah,
Like,
questions
there's free
from, are there
clinics
any
out there
means
for birth control. Is
for
there
folks?
anything out there?
There are free clinics too for medications.
There are?
Yes, they're annoying and you have to wait in long lines and you have to be extremely patient and tolerant, but yes, they do exist.
And how do you go about finding out where those are?
I can, like Nikki probably would be able to help, the county, yeah.
Generally, the county mental health system is what is set up for that. That's the public
Is it
mental health system.
211? Isn't that like a
I don't know the information number.
I think, yeah, it's
211.
211.
Find that out.
Dial 211.
Okay,
Yeah.
thank you.
In this area, the local Department of Mental Health is Arcadia Mental Health.
Okay,
In Arcadia.
thank you very much.
That would be the place to seek out.
I think you said, and I think I read, that there are, did you say there are lesions in the brain of somebody who is bipolar?
That, in research, one of the things they've seen is that there's, increased likelihood there will be lesions on the brain of someone with bipolar disorder.
Okay.
Correct.
I had a brain seizure one time, and so I'm on anticonvulsant, and it is the same medication as Lamictal. How are they in the same spot? I mean, how does that work?
That's a great question. I don't have an answer to it. The question is, how does the medication actually work?
I mean, why is it the
And-
same medication as that? I was thinking maybe in that same area of the brain fires certain, I don't know.
Not so much that. I think, again, it was discovered more serendipitously, meaning that it wasn't like targeted that, because of this, we think it'll do that. It was more just seeing that these medications will work, and I don't know the exact mechanism in the brain for which they work, but it's more we're judging more by symptoms and by changes in behavior, and that's how we see these things work. Yes.
I noticed, Karen, that you said you started to attend the 12-step program, and do you feel that that is a form of cognitive behavioral therapy?
Yeah, I do.
So that goes up even there.
I mean, I can't,
So the question is if the 12-step programs are really like a form of cognitive behavioral
you know,
therapy?
I mean, I'm always an honest person, so I always just kind of say the truth. For me, there were times where I needed more care than the 12-step program could help me with.
Okay.
So if I was having an episode, or if I was in the middle of something, I wouldn't necessarily go to a 12-step meeting. I would go and call my therapist, or I would go and sit with my dad, because I needed more care.
But do you feel that the tools that you learned were what actually what took away from that, not the meeting itself?
Oh, yeah. Oh, you mean like in general?
It's just, do you feel that in combination with the medication, those tools that you learned as a type of cognitive behavioral therapy really helped improve
Absolutely.
attitude and perception?
Absolutely. My attitude and my perception has changed because of the 12-step program, for sure. For sure. You know, being grateful and all these things, these tools, Attitude, cognitive behavioral, it's cognitive changes, yeah. Good stuff.
With your hospital stays, how long were they? I mean, you said you've been in the hospital 4 times. Well, last year, my son was in and out of the hospital 8 times in 1 year. I mean, that's more than every other month, but how long were your stays on the average?
My stays were usually pretty short. My longest stay was about 2 weeks. So, yeah.
What is it like when you're in the psychiatric hospital?
The question is, what is it like in the psychiatric hospital?
It's awesome. You get little slippers and got to bring lots of quarters for phone calls and the food. I recommend for anyone who has bipolar disorder or any other brain disorder to go to NAMI and do the peer-to-peer course, because the last chapter, the last week, they talk all about the hospital, like what to expect, and it's a little bit scary. It's people coming in on their last leg, and there have been times where I've been scared. I went to Olive one time, and oh my god, that was so scary. It was so scary. One woman was like hitting on me, and then this guy was on the phone, and he's like, "Your voice sounds like nails down a chalkboard." I was like, I'm sorry. So it was just kind of a lot.
Just that a lot of times afterwards, people will describe it as it was a trauma. Going through that is traumatic.
Yeah.
And usually what leads you in there, you're not aware of what's going on. You don't know what's happening. And then you're put in this place where you're locked up and made to wear these.
Yeah, you put in
funny
handcuffs
slippers
there in
and
the first place.
all sorts of things. So it's, while, as Erin even said, while it is necessary for safety and for stabilization at times,
Can I say
the
something about?
experience can be traumatic for the person, then we need to be able to acknowledge that and address that.
One way to make it less traumatic, though, is for me, like this past time, a doctor said, you're going to have to go to the hospital. And so this time I was like I actually like packed a bag. I was like, okay, if I have to go, I have to go. I'm going to pack a bag. I'm going to pick my own stuff out. In the end, I didn't have to go, but I was a participant in the process of going to the hospital. I think that's less traumatic.
Yes.
I have two questions. One of them is, I hope I don't forget the second one. One of them is, you know how they're doing all this work and talking about the neuroplasticity of the brain. How can that, is there any way that that can apply to this? That the brain actually can structurally change through whatever it is, and that whole idea of neuroplasticity?
Yeah, so the question refers to this idea of neuroplasticity, the idea that the brain is, development doesn't just stop in the brain as we once thought it did, but throughout entire life, the brain can kind of sort of regenerate, so to speak, create new connections and develop. And the question is, does it apply?
How does it apply to this? Yeah.
How does it
If
apply
we're talking
here?
about
And
perhaps lesions in a brain, can that change that?
were you going to say something about
Yeah, I have very strong feelings about doing stuff for your brain, and like, that could mean a lot of different things, from exercise and all this other stuff. But I mean, like exposing yourself to new things, or challenging your brain. Doing things that go like left, right, left, right. I mean, there's activities you can do for your brain, and I feel like I went from being in this total fog in my brain to being more and more and more and more cognitive and more functioning. So I think you can definitely improve. And meditation is, I'm telling you, it's amazing.
One of the things that is being, there's a lot of research looking at these different like brain fitness things that are now very popular, like Lumosity is kind of a popular one. A lot of research actually behind these things and research projects that look at tailoring these things to particular folks or particular conditions. And we do see improvement. You see improvement in things, in all those cognitive functions, concentration and focus and memory. And so it just kind of reminds us, yeah, we can do a lot with the brain. We can do a lot to keep our brains healthy as we go forward. One more question, last one.
Does it cost anything to use Lumosity?
The question is, does Lumosity cost anything?
We
There
looked
is
on the
a
internet,
Do
they
what?
wanted all this information.
There is
your
a-
address.
It's called luminosity.
Lumosity is one of the brain training fitness programs online. There is a cost to it. I don't think it is very much, but there is a small cost to that.
I think it's like $10 a month or something.
There's free things. If you just type on the internet like brain exercises, they'll give you activities.
If we can remember to do that.
Yeah, remember.
So with that, I've a couple of
one more
closing
question.
remarks. A couple of closing remarks. I'm happy to talk to you after.
Okay,
afterwards.
great. Take care.
First, I'd please like to invite you to thank Erin for coming here. Very grateful for the small gift
Thank you.
for her great work with us. She comes back every year to do it. We appreciate it. And again, I'd like to thank all of you for being here. And on behalf of your relative who may never thank you for being here, for getting this education and learning about this, all of this important information. In the next few weeks, if you are dealing specifically with depression, or depression is a severe part of your bipolar disorder, you may wish to come back next week for that. We're going to do 2 weeks on schizophrenia. If you're dealing with schizoaffective disorder, a lot of overlap, a lot of the psychosis, you may wish to come back for that part as well. We're going to do a week dealing with trauma and PTSD. And then our final week, which I invite all of you back, which is the helpful roles and skills that you as family members can provide for your relatives. So lots of good stuff coming in, and I'll invite you to come back and join us for more. Thank you very much.